In general, skull x-rays are not the easiest to read. With this provided clinical information, you'd like to exclude a fracture. Knowing the exact location of the head injury would make it easier to concentrate on the area of abnormality. So going into details about the history of the trauma would make it easier, but if that's not the case, try to change the window to assess where you have soft tissue swelling. Now by doing that, you notice that there is asymmetric soft tissue swelling along the right side of the head, in particular in the parietal region. Once you see that, make sure you don't have an underlying fracture. And looking carefully at the area of concern, you'll notice that there is a lucent line. Don't confuse sutures with fractures. Sutures have a normal anatomical location and have this zigzaggy appearance as you see here. Compare that to the fracture line, you'll notice that this has a more smooth appearance that extends into the cortex. Sometimes the cortex may be displaced. To make this easier on yourself as well, compare this to the contralateral side. Sutures are usually symmetric in appearance and you don't see a line here. This is the fracture on the lateral radiograph, and as you see how the fracture line is very smooth, does not have a zigzaggy appearance. This is a normal suture line underneath. Notice how the normal suture line is zigzaggy and smudgy in appearance, not as clear as the fracture. Once a fracture line is identified, you have to make sure that the patient does not have intracranial bleeds. So a CT scan is in order. This is the CT scan of the same patient. We're looking at the bones now, and we're going to concentrate on the suture lines. Here you have a zigzaggy appearing sagittal suture. This intersects anteriorly with the coronal suture on each side. Posteriorly, you'll see another famous suture, which is called the lambdoid suture. The coronal suture separates the frontal bone here from the parietal bone here. Notice again the overlying soft tissue swelling. Look carefully at the area of soft tissue swelling and you'll notice a very difficult to detect linear non-displaced fracture in the right parietal bone. Apply the same rule that we applied on the skull x-ray and make sure that this is not a suture by checking symmetry. This is the left side, which is normal. Once you see a fracture, make sure an underlying hematoma is not present, and unfortunately there is a hematoma in this case. We learned from previous snaps that intracranial bleeds could be classified into intraaxial within the brain parenchyma versus extraaxial outside it. The way this hematoma displaces the brain inwards without associated surrounding edema is consistent with an extraaxial bleed. We learned from before that extraaxial bleeds could be subarachnoid, subdural, or epidural in location. If you see a bleed that is biconvex or lentiform in appearance and that's confined by sutures, that's epidural in location. For further differentiation of epidural from subdural hematomas, please refer to one of our earlier snaps present on our YouTube channel. Remember how the fracture line was difficult to detect? It's much easier to detect such abnormalities utilizing the sagittal and coronal reformats. On this sagittal image, you'll notice the zigzaggy and normally located lambdoid suture with another line that's not normal here. This is the fracture line that we detected earlier, which is much easier to see on the sagittal image. It's even more easier to see on this coronal image. Notice that you have an extra line here that is not present on the other side, consistent with the fracture. So this was a quick case about traumatic brain injury with a non-displaced fracture and underlying epidural hematoma. Thanks for watching. Today's snap is a quick snap for juniors. What do you see on this chest X-ray? What's very obvious is that the cardiac shadow appears enlarged. Now, such a finding might make you think about cardiac disease. However, it's very important to notice the way the examination was performed. We know that a cardiothoracic ratio that exceeds 50% meaning that the heart is more than 50% of the thoracic diameter, is abnormal. But you should always remember that you can only rely on this rule if the X-ray is done in a standard way. A standard chest radiograph is performed in a patient who is standing in suspended full inspiration, well centralized, and in postero-anterior projection, meaning that the X-ray comes from the back of the patient and hits the film in front. The X-ray that you see here is a portable supine film, and in portable supine films, the examination is performed in anteroposterior projection, meaning that the X-ray comes from in front of the patient, hitting the film on the back. That's because the patient could not stand and he's lying. So always keep an eye to how the film is performed, because if it's not done in a standard way, you're going to have magnification, especially of the cardiac shadow. Believe it or not, this is the same patient. This is only performed at a different time in a standard way, meaning that the patient was standing and performed in a postero-anterior projection. And when performing the film in a standard way, there is no magnification and the heart appears of normal size. Remember that technique is important, and if you perform a film in an AP instead of a PA projection, there is magnification. So be careful when talking about cardiac enlargement on an anteroposterior film. That's it for today. Thanks for watching. This patient has several abnormalities, but please concentrate on the vascular structures. Here's another look. Before we proceed with the other case, let's look at this normal case. Again, concentrate on the vascular structures. This bright structure here is the aorta, which divides into the right and left common iliac arteries. So this is the right and this is the left common iliac. Note how the iliacs are followed by the right and left common iliac veins, which form the inferior vena cava that goes all the way up. Here's a coronal image that shows the aorta with the adjacent inferior vena cava and both iliac vessels on each side. Now back to the abnormal case. The density of the aorta is equal to that of the venous structures because this is a portovenous phase. Now this atherosclerotic aorta divides into right and left atherosclerotic common iliac arteries. As we agreed before, the common iliac arteries are accompanied by the common iliac veins, but notice the unusual thing that happens here. So instead of the right and left common iliac veins joining to form an IVC that should run along this side of the aorta, you see the veins on each side. Now let's continue with these vessels as you go all the way up. The left vein joins the left renal vein, which then cross anterior to the aorta to form what we know now as an IVC. When this happens, this is a congenital variant that is called a duplicated inferior vena cava. So let's look at this again in the coronal image. You'll notice that the atherosclerotic aorta is surrounded by venous structures on each side. The vein on the left joins the left renal vein and then crosses anterior to the aorta to join the other vein and form a real IVC. Although such a finding is commonly incidentally discovered on abdominal CTs or other studies, it's an important observation. Remember that such a finding could complicate interventional procedures such as placement of inferior vena cava filters. Also keep in mind that you place these IVC filters to prevent clots from progressing from the lower limbs up to the lung. And such a variant may lead to failure of the device, since if you close this vein here, a clot might pass through the other unprotected way. To summarize, you should not see veins on each side of the aorta, and if you see that, this could be a duplicate IVC. A duplicate IVC classically has a vein on the left that joins the left renal vein, which crosses anterior to the aorta. And such a finding is important to recognize because it may complicate procedures such as placement of an inferior vena cava filter. Thanks for watching. This is a CT scan of the chest without contrast, and something really looks funny here. Have you noticed it? This is another image on the same patient. This cut is taken at a different level, showing left upper lobe disease, but have you noticed something else? Before we continue with that case, let's look at a different case. So this is a CT scan without intravenous contrast as well on a different patient. Normally, without intravenous contrast, you cannot differentiate the blood pool from the myocardium. So the unenhanced heart shows a uniform single color. In addition, without IV contrast administration, you cannot differentiate the blood inside the aorta from the aortic wall. A common reason to see a wall of the aorta is the presence of calcific atherosclerosis. Excluding that, you should not see a clear wall. Now that you know how a normal unenhanced CT appears like, let's go back to our case. So notice how you could differentiate the cavity that contains blood from the interventricular septum. You could also differentiate the cavity from this peripheral myocardium in the wall of the left ventricle. The reason this is happening is because the cavity contains blood that is very low in density, and this is a neat sign of anemia on CT scan. For residents, if you measure the density of the blood here, it will likely be less than 35 Hounsfield units, which is very low. Appreciating a relatively dense interventricular septum is called the dense interventricular septal sign. Another sign of anemia in this patient is that the aortic wall is clearly delineated and relatively hyperdense. This is called the aortic ring sign. Although anemia is diagnosed based on clinical and laboratory findings, you could see it on a CT scan as well, which is a neat thing. The first sign of anemia is a density of the blood pool that is very low, measuring less than 35 Hounsfield units. The second sign of anemia on unenhanced CT is the dense interventricular septal sign. And the third sign of anemia is the aortic ring sign. Thank you for watching. See you with more cases later.